Welcome to the first grand round of 2023, and it gives me an enormous pleasure to welcome our speaker this morning, Professor Jon Odorico. Jon is Professor of Transplant Surgery in the University of Wisconsin in Madison, and is also the Director of both the islet transplant program and the whole pancreas program in Madison. Jon is a world-renowned transplant surgeon scientist, with a productive and externally funded research program focusing on the area of pancreatic development and stem cell biology. Jon did his bachelor degree in chemistry in New York before studying medicine in Duke before his medical degree in New York, and then he did his residency in general surgery in Philadelphia and his transplant fellowship in Wisconsin, where he's been ever since. He's held a number of key national and international positions, including president of the International Pancreas and Islet Transplant Association, and he's chair of the UNOS Pancreas Committee. He's also the scientific co-founder of Regenerative Medical Solutions, a company looking at the whole area of stem cells for beta cell replacement. And this morning, Jon is going to be talking about the evolution of beta cell replacement for the treatment of diabetes. Jon, welcome to Oxford, and we really look forward to hearing what you've got to say to us today. So over to you, Jon.
Thank you, Paul, and thanks for everyone for making it this morning, virtually or in person. It's really a pleasure to be here, and delighted and honored to be able to visit your prestigious institution and learn a little bit about the institution and its history. Apropos to the amazing history that is here, I thought I'd talk a little bit about the evolution of beta cell replacement as a treatment for diabetes. But before I get into that, I just wanted to say thank you for Paul for his gracious hosting of my wife and myself during our visit so far. And we've had a great visit as well with surgical scientists and the clinicians yesterday. Learned quite a bit about what research and clinical activity is going on here in the transplant division. What I thought I'd do is talk about the evolution of beta cell replacement. This is islet cell transplantation, pancreas transplantation, and what the future holds, and the near future holds actually, with stem cell derived islets as a source of unlimited supply, potentially unlimited supply of islets for patients. The first attempts at beta cell replacement were actually about 20 years after Paul Langerhans identified the islets in the pancreas, and about 30 years before the discovery of insulin. Von Mering and Minkowski first understood that the pancreas was the seat of control of blood sugar, and then they transplanted pieces of a dog pancreas to restore glycemic control. Dr. Patrick Watson-Williams at the Bristol Infirmary also attempted a xenotransplant with a portion of a sheep pancreas to cure and try to treat a child who had diabetic ketoacidosis. Some other first attempts at beta cell replacement, Dr. Pybus in Newcastle unsuccessfully tried pancreatic slices from human cadavers. And this was, is that working okay? Is the volume okay? Subcutaneous, and we'll get back to the aspect of a subcutaneous site, because this is a problem and a goal, but also a problem. We'll talk a little bit more about that. It was not until 1972 when Paul Lacey in St. Louis and Camilla Ricordi reversed diabetes in rodents with islet transplantation. Lillehei, Kelly, and Sutherland at the University of Minnesota in 1966 cured diabetes by a pancreas transplant with the first successful human cadaver pancreas transplant, and then subsequently first human cadaver islet transplant at the University of Minnesota in 1974. So these were the first, I would say, haltingly slow and steady, but steady progress in the field of early beta cell replacement in humans to treat diabetes, many before the advent of insulin. This is a picture of the first human pancreas transplant, enterically drained, not bladder drained, which was more common thereafter. Lillehei and Kelly, 1966 at the University of Minnesota. Very few pancreas transplants were done in the first 30 or 10 to 20 years after that, and then things picked up, and I'll show you later. The innovators in pancreas transplantation, I think, would be these three people: David Sutherland at the University of Minnesota, Hans Solinger at University of Wisconsin, my mentor, and Robert Corey, then in Iowa, and then subsequently in Pittsburgh. These gentlemen, I think, are the pioneers in pancreas transplantation, and much of what was developed over the first several decades in pancreas transplantation was largely attributed to these gentlemen. Some of the innovations that occurred were, as I've listed here, bladder drainage allowed early successes in the era of not such great organ preservation and immunosuppression, but allowed the kind of the takeoff of the procedure and greater success and better volume over the first in the 1980s. Mycophenolate mofetil, otherwise RS61443. I'm probably dating myself because that is the name of the drug that was used in Wisconsin before it was called Cellcept and mycophenolate mofetil. That was the study drug number. Now Myfortic is what's commonly used, and tacrolimus, and of course UW solution, which is still one of the more commonly used organ preservation solutions in the world. I will also mention that your colleague, Rutger Plug, was involved with the development of UW Solution at the University of Wisconsin when he came there as a visiting professor and a trainee many years ago, which he contributed to the early development of this organ preservation solution when he was working with Fred Belzer and Jim Southard. Hans Solinger was one of the first pioneers of using mycophenolate mofetil, and so we were early adapters at the University of Wisconsin as a part of studies. And I would say that possibly in the field of pancreas transplantation, these two things, UW solution and mycophenolate mofetil, had the greatest impact in terms of its current successes. Whereas the early results prior to the development of some of those innovations were not too great in pancreas transplantation, things have improved quite substantially over the years. This graph shows the simultaneous pancreas kidney transplant results in terms of graft function and graft survival, insulin independence rates, and pancreas transplant alone on the right over sequential eras. And you can see that there's been steady improvement in terms of the outcomes, but there are still challenges. The successes that occurred during these eras were largely due to reduced technical failure rates and improved immunologic graft survival rates. And I point out this is the data from Angelica Grusner, who manages the pancreas transplant database. This shows the technical failure rate over several decades. And when I've been in the field for almost this long, and so I think the improvements are due to some of the things I show here: UW solution development in the 80s, immunosuppression with mycophenolate mofetil and tacrolimus in the mid 90s, and then more recently donor risk factor assessment. We have a better sense of what are the key factors of a donor that lead to less good outcomes, so we can select donors a bit better. And then induction therapies are better now with Campath, alemtuzumab, and ATG, or anti-thymocyte globulin. The immunologic, not only the technical graft loss is reduced over time, but the immunologic graft losses are also been lower over time. And I think some of the contributing factors there are immunosuppression, better graft monitoring with both biopsy and Luminex, flow cross-matching, and induction therapies. So these are the things that have contributed to now very good outcomes with very low immunologic graft losses or technical graft losses in the first year. So with those improvements and those innovations, it's fairly routine, for example, at our center, that we have an ideal outcome. Not all the time, of course. There's plenty of complications that occur in pancreas transplantation, and there's some problem in almost 80% of patients, but we can get them through it. But what's more routine now is no bowel prep, no ICU stay, no NG tube, selective drain placement, Foley catheters removed at day 2, quick return to bowel function, and a very short length of stay, slightly longer for the SPK transplants or simultaneous pancreas kidney transplants and less long for the isolated pancreas transplants. So when the pancreas works well, which is most of the time, but not all the time, the outcomes are really, really quite good, and patients are very grateful. This success has allowed us the field to understand the impact of pancreas function on outcomes and patients' lifespan and longevity. And this study from the Grusner group, looking at patient survival, looks at all the organs, but I'll focus your attention just on the simultaneous pancreas kidney transplants and the pancreas transplants. And what was done was comparing the patient survival after transplant to that of the waiting list. And you can see that there are substantial improvements in terms of average lifespan. There are some potential selection biases here. So they did propensity score matching, and that not only maintained the difference in benefits of patient survival in both types of pancreas transplants, but they showed that it was actually even slightly better. So there are benefits in terms of patient survival with pancreas transplantation. Single center studies have shown that. This national registry has shown that. And there are, when the pancreas works, there are really good things that happen for the patient. Some data from the last 10 years of our center. We've been a center that imports pancreases for transplant, and I know that Oxford does that as well because you have a national system. We've always at our center done national and regional imports. And you can see that on the left-hand side, the patient survival, and on the right-hand side, the pancreas graft survival is fairly similar regardless of where the pancreas comes from. So we continue to import many pancreases. These are the patient and pancreas graft survival for some recent data from our center, spanning 20 years, looking at both short-term and long-term outcomes. And one of the things that I want you to take away from this slide is that of all types of solid organ transplants, the best survivals, patient survivals, are in patients with pancreas transplant alone. And so we think that that's a population that is well worth offering a pancreas transplant to. These are patients with normal kidney function, hypoglycemic unawareness, or failure of current technologies, that we see excellent pancreas graft survival in this population now. In the past, historically, the solitary pancreas transplants, those done without a kidney, had worse outcomes. And we still see that in the pancreas after kidney population, the sequential transplant. You see that in the blue on the right-hand side. But with the PTA population, that is really, in terms of pancreas graft survival, in our hands, is really paralleling the SPK transplant in terms of graft outcomes. So that's substantially improved for us over the time. And you can see in the bottom there, in the bottom right, there is the half-life. We can tell patients that expect the average half-life of their pancreas transplant alone is about 12 years, that of a pancreas graft and an SPK transplant is 14 years, but it's substantially lower in the PAK transplant. So if in this case, because the PAK graft survival is so low, we recommend a pancreas SPK transplant if they have kidney failure as a first option, even if they have some living donors available. And then a PTA patient in the selected group of patients that have higher mortality and more reduced quality of life due to hypoglycemic unawareness. With those improving results, though, it's really striking, and anyone in the field will tell you it's surprising and disappointing that there's a decline in the volume of pancreas transplants in the United States. I don't know if that's the case in the UK or in Europe, but in the United States, we're seeing declines in the volume of pancreas transplants being performed. I think there are many reasons for this. Some of them are listed here. Our donor population is certainly getting older, more obese, and more diabetic. So there are obvious reasons why that would be poor outcomes for pancreas transplants. There's, of course, better diabetes care and better access and better penetration of those technologies into the diabetic population. So that's clearly having an effect. And because there's better education, less smoking, better diabetes care and education, there has been observed in a number of centers, a number of countries across the world, delayed progression to nephropathy. And if the main indication, the most common indication for pancreas transplantation is the simultaneous pancreas kidney transplant, it's not a surprise that the population is changing. That is, the referral population is changing, and that patients are aging out, so to speak, before they end up coming to need a kidney. So they are developing cardiovascular disease, other comorbidities, other problems before they develop end-stage kidney disease, and they're eligible for an SBK transplant. So there's a change in disease patterns and change in referral patterns. There's also a steady and problematic, I would say, possibly not the best word, but a lack of acceptance in the endocrinology community for referring non-uremic diabetics for either pancreas or islet transplantation. There are systems in place, I think, in some institutions that are encouraging that. For example, I go out and talk to endocrinologists on a regular basis and talk about islet transplant, pancreas transplant options for these patients. But there's better biological and technological therapies for these patients that are available too. So there's competition there, and that competition is good because it floats all boats, so to speak, and that patients with diabetes benefit from the competition, from the better technology and other biological therapies. And sometimes it's a debate about which patients should be offered pancreas or islet transplantation, which patients should be offered technology. I think it depends on the patient. It depends on their stage of their diabetes. It depends on other comorbidities. It depends on whether they have kidney failure or not and are on dialysis, and whether they have hypoglycemic unawareness, and what might not, an islet or pancreas transplant might not be right for a patient at this point in time, might ultimately be a good choice for that patient at a subsequent point in their diabetes evolution. In the United States, there's the UNOS and OPTN, which have caused a lot of scrutiny of centers, and because of that, there's a lot of risk aversion. And so that there's good data in the United States that the pancreas donor risk index, which is a measure of quality, has gone down, and that the cold ischemic time has gone down, meaning we are much more stringent in terms of our donor acceptance, which is reducing volumes. So these are some of the things that have reduced volumes. And then since the pandemic, there have been a number of other things that have contributed as well. So the volumes in the United States, sadly, are going down despite improving the results of pancreas transplantation. And not to be too depressing about this is a bit of a vicious cycle, actually, because what you have is that if there are fewer pancreas transplants being done, trainees are not getting exposed to the procedure. Then they don't have the comfort when they go out and become a faculty member to do more pancreas transplants. They're a little more risk averse, a little bit unsure, a little bit less comfortable with the procedure. And then that cycles back, and a negative vicious cycle can occur. Less center emphasis on the developing pancreas transplant programs. But I think, in fact, the pancreas transplant program is an option for further growth of any transplant program. So as Bob Dylan said, times are changing and we have to adapt. But before we go to that, I just want to talk a little bit about islet transplantation. And Paul Johnson and your team here has developed a fabulous islet transplant program. These are some results of the long-term outcomes of islet transplantation from other European groups. The procedure was not very successful before the Edmonton trial in 2000, then the Edmonton trial, which promoted 2 pancreases worth of islets and elimination of steroids, had better success, and islet transplants are infused into the liver. And then, of course, the patient is on now similar immunosuppression that they're on for a pancreas transplant. These are some long-term outcomes and in different types of islet transplants, and you can see that the outcomes are good. This is the data from the long-term data as well from the Edmonton group that was recently published, showing insulin independence rates at 20 years and graft function at 20 years as well. But there's a chronic and extensive onslaught of attack on islets when they go into the liver, and it's not an ideal site in the liver. And there are many issues that affect, including the health of the islets, that including immunity, drug toxicity from the drugs that through the portal circulation have higher levels that the islets are exposed to, IBMIR, or instant blood-mediated inflammatory reaction, which affects the health of the islet and causes hypoxia. And then when we take the islets out of the pancreas, we digest some of the collagenase. Using collagenase, we digest some of the extracellular matrix, which causes disconnection from nerves and extracellular matrix and blood supply, which also can cause reduced health of the islet. So these are some of the things that why we don't get perfect survival long-term of an islet graft when put into the liver. There's been activity in North America and Europe, primarily with islet transplantation. These slides from Thierry Berney, a colleague and friend of Paul and I's. In the United States, a huge effort and a huge expense was put towards phase 3 trials of islet transplantation over the years, both in islet transplant alone and islet after kidney transplantation. These are some of the published results. However, despite those good results and those multi-center trials, most of the activity currently is in Europe and the UK, Scandinavia, but very little is in the United States. You can see here that there's practically no allo islet transplantation work in the United States. There isn't at our program. We had a program from 2002 to 2008, more or less. We do islet auto transplants, but there's no healthcare coverage for these. Is one of the reasons the Medicare does not cover it at our center, whereas the programs in the countries where it is practiced and delivered are programs that have national healthcare systems. So unfortunately, in the United States, that's not the case. Another reason is that in the United States, unfortunately, the islets are regulated like a drug. They're not regulated like a solid organ transplant, and as they are in the UK. So we're at a disadvantage, and a private company has developed an islet transplant drug called Don Islet Cell for donor islet cells. And this is remarkable in that this is supposedly a new drug that is now invented by this company, whereas people 50 years ago were putting it into humans. And, as we all expect for a drug, it needs to be very strictly controlled in terms of its dosage, purity, potency. That's not true when you isolate islets from a human cadaver pancreas or any pancreas. It's very variable in dosage, purity, and potency. We've tried to lobby our FDA to switch their regulation from a method of regulating it like a drug to a solid organ transplant or tissue, and unfortunately, we've been unsuccessful so far. We don't know how much it will sell for. I think this will potentially restrict our ability to deliver islet transplants to patients in the United States ultimately. It's unclear where this is going in the United States right now. But I'm not sure, I wouldn't hold my breath about the FDA changing their stance on this. Ultimately, both for donor pancreases and donor islets from human cadaver donors, the supply will never meet the demand. So I think it's necessary to think about changing, and our center has thought about that. And because we've been working in the field of stem cell derived islets for a number of years. Our current beta cell replacement therapies, as I mentioned, pancreas and islet transplantation, have a number of issues. One is the insufficient supply of human donors. They both require immunotherapy. In the pancreas, there's major invasive surgery. In the islet transplant, there are limitations based on site in the liver. For an ideal curative therapy for diabetes, we need a renewable source of insulin-producing cells. I think there's a benefit to having a retrievable site that is safe with better islet survival than in the liver. And we need a way to protect the islets from immune destruction. In the next few slides, and I'll tell you a little bit about what's going on in the field of stem cell derived islets. And when I mean stem cell, I mean human pluripotent stem cells. Those are embryonic stem cells or induced pluripotent stem cells. And this field really started with the isolation of primate embryonic stem cells from rhesus macaque and marmosets by James Thompson at the University of Wisconsin. And then subsequently by Yamanaka and Thompson with induced pluripotent stem cells, reprogramming adult cells and fetal cells to become embryonic-like subsequently in 2007. I was fortunate to have an association with Dr. Thompson a number of years ago when I was starting my research effort. And I read his paper here that I show you here and saw this line. And that says human ES cells would offer new exciting possibilities for transplant medicine. And I thought, here's the solution. We can fix this problem we have of insufficient organ supply in a couple of years. So I thought, well, I'll dive in. There were many detractors for myself and others entering this field. And there were a number of people working on different lineages, liver, heart, nerve at the University of Wisconsin, and then subsequently across the world, of course. For me, there were a number of detractors early on. They said, you're crazy. Why are you doing this? It's never going to work. But then good ideas are always crazy until they're not. The Google co-founders thought that way. And I think now people would say, it's not such a crazy idea. We're actually coming to clinical fruition. And in fact, I'll share with you the recent clinical trials in this field. So people have thought about how to differentiate cells. And it's taken a long time. It's taken about 20 years for us to get to the point of where we can take this blank slate embryonic stem cell to something that is like a beta cell-like or an islet-like cluster. Initially, they were undirected differentiation with serum, that led to a few cells, but not a plethora of cells. Eventually, learning from islet development, try to recapitulate islet development in a dish using multi-stage protocols. You can get stem cell derived islets that have some phenotype of islets, but until recently, the function has been less substantial. And although you have insulin expressing cells, they hadn't until recently really responded well to glucose or other secretagogues in a dynamic fashion. We are seeing evidence of that in a better way now. So there seemed to be a block at this later stage of what's happening during the developmental process. And I'll say, of course, it's taken about 20 years to get to this stage of us being able to really direct the differentiation in a finite way. But think about evolution, how long it took evolution to do this in a way in millennia. So the fact that it's taken 20 years is maybe pretty good. But for a diabetic, it's not fast enough, of course. So recently we've gotten to, the field has gotten to a position where there's dynamic responses to glucose, and I'll show you some data there. In our lab, we can make these islet-like clusters. This is an example here on the left of insulin and PDX, as pancreatic duodenal homeobox, a transcription factor that's expressed during both early development and pancreatic progenitor stage, as well as necessary for insulin secretion and synthesis in the adult beta cell. And so we go through stages, can quantify the cell numbers. And on the right-hand side, this is a cell line that glows green when the insulin is transcribed. This is the MEL1 cell line produced by Elefanti and Stanley at Melbourne. And so you can see here that these green clusters without just epifluorescence are showing insulin production, and the stimulation index response to glucose on the right-hand side in terms of static glucose stimulated insulin secretion. As an example of the function in animals, this is one experiment from our lab where we took NOD, SCID, gamma-C knockout mice, immunodeficient mice, that expressed the rat insulin promoter and diphtheria toxin receptor, human diphtheria toxin receptor transgene, and then made them diabetic by administering diphtheria toxin. It's a nice model. I think it's a little bit better, in fact, than the streptozotocin model, which is a standard model in the field, and then transplant either human islets or stem cell-derived islet-like clusters, that's SCILC, and then look at their function. These clusters can stain with dithazone as well. There's some examples here and immediately post-transplant under the kidney capsule in rodents, a standard model. And you can see here that there's glycemic control in this tracing, shows induction of diabetes and then reversal of diabetes and the immunostaining of the grafts after transplant, after removal. When we measure the human C-peptide in these as a measure of insulin function from and islet function from the graft, from the human graft, which we can differentiate from the mouse C-peptide, you can see that in some animals there's, in yellow, for example, there's very little C-peptide produced. In other animals, there is increasingly amount of C-peptide produced over the first weeks. Note here, though, that the number of human islets going in are 2,000 as a positive control, and that's in the gray and orange bars, whereas the in the top and the other bars have 12,000 islet equivalents. So in essence, what we're saying here is that the human stem cell-derived islet clusters are not quite as potent as human islets, and there's variable, and they don't produce immediately the insulin that we'd hope for. So there's gradual maturation and in a dynamic way after the transplant, showing some maturation of the graft. This is just one example from the lab, and some other examples of the histology of the immunofluorescent staining for islet-like markers, for these stem cell-derived islet-like clusters transplanted under the kidney capsule. So we and others have developed islet differentiation protocols. These are some examples of published protocols. They're all a little bit different. There are similarities, though. It's remarkable that we can, in other words, from islet development point of view in biology, get to almost the same endpoint with multiple different methods. Nonetheless, so the field doesn't fully understand what are the absolute necessary factors and what are the extraneous factors. The ones that are common are probably the necessary ones. The types of cells that we get to at the end here are islet-like. They have some progenitors in the clusters. They have some off-target cells in the clusters, I would say. They have plenty of beta cells, but they also have some insulin and glucagon co-positive cells, which are immature islet-like cells in the fetus. So they have some features of maturity, but they have some features of immaturity as well. And in fact, up until recently, dynamic insulin secretion based on perifusion assays has not been shown. But now has been shown, and I'll show you a slide of some data from those groups. But the beta cells don't exactly have an adult gene expression profile. The clusters don't have an adult gene expression profile. We'll talk about some of the things in my lab that we're working on getting to that point so that they're more adult-like. And the protocols that I've used to derive these, as I said before, are a variety of different conditions. As I said, there has been acquisition of dynamic function in published protocols now. These are some examples. You can see that there's first and second phase insulin response, as you would expect to see in a normal human islet. However, the degree to which it is less than that of a normal human islet. And that's pretty consistent above the across labs. Now I did it. I'm sorry about that. Let's leave it there. I better leave it there. Better not touch it. Any suggestions? Not quite advancing now. Oh, I'm not seeing this. Come down to this one here. Oh, good. So although the islets that are not fully mature and can be shown and developed in vitro, despite that, the field has moved to clinical trials by a number of companies. One is Vertex, and another one is ViaCyte in San Diego, Vertex in Boston. This trial is underway now. We are participating. I understand that Paul Johnson's group is also interested in participating or planning to participate. I think this is a very exciting trial. This is state of the art. I'll just go through a little bit of details of it for you because I think it represents really now coming to clinical fruition. And I'll show you a little bit of information about the ViaCyte trial. So this is a phase 1/2 trial of the stem cell derived islets. They're from a human embryonic stem cell line, a third-party line, unmodified, wild type, in patients with type 1 diabetes and hypoglycemic unawareness, severe hypoglycemia. This is a typical population one would offer islet transplantation to, cadaver islet transplantation, and it's done more or less the same way as cadaver islet transplant. So the cells are transported from their company to the lab here, such as here, would be infused either in the radiology suite or in the operating room into the liver. So it's intraportal. Patient is given immunosuppression, the same immunosuppression that one would typically use for an islet transplant patient. Early steroid withdrawal or no steroids, induction therapy. And so it basically pivots off of the islet trials that have been an Edmonton protocol and the islet trials that have been done here in the UK, Europe, and the United States. It's an adaptive trial design, meaning there are a few early, a pilot, 2 patients given a half dose, then 5 patients giving a full dose, and then a subsequent patients. And there's a break between each of the part A, B, and C so that there's an analysis of the data and assessment before moving on to the next part. Right now, the study is in part B. I've seen data from 3 patients. The primary endpoints are freedom from hypoglycemic events and glycemic control at the 90-day and 1-year time points. The donor cells are blood type A, so it limits the recipient population. And they're fairly stringent enrollment criteria for this trial. Data has been published at the American Diabetes Association this past spring. And right now, the early results look promising. A year ago, basically, was this press release with the first patient who was transplanted in Boston, who was off insulin now and has been off insulin for a better part of a year, and is quite remarkable with a half dose, what they expect to be a half dose of the cells. So you can see that some of the data here that's been publicly released, fasting C-peptide and stimulated C-peptide are easily measurable, where they weren't pre-transplant in type 1 population. Hemoglobin A1C is improved, and at this point in time, the daily insulin dose was reduced significantly, but subsequently, we've seen data that the patient is fully off insulin. Now, that's the Vertex trial, which I think is very promising and just pilots and builds off of the clinical cadaver islet transplant results. ViaCyte, another company, has done different types of trials. We're not involved with this trial. What their trial involved with, and there's been two trials that have been published, two trials that have been done and reported. The first one was using pancreatic progenitor population, not a fully mature differentiated population, but a pancreatic progenitor population, which was placed into a device, a Theracyte-like device called Encaptra, which is fully immunoprotective, and then implanted under the skin. And you can see here the device in the upper right and the example of some cells immunostained in the device after differentiation in vivo in the rodent. This is rodent data here. The results are as shown here on the left, in that there were 19 patients. They also put in sentinel devices that they pulled out and studied as a measure of kind of a biopsy type measure. Unfortunately, they did not see very much C-peptide in the grafts that they pulled out, and no measurable C-peptide in the blood in these patients treated with this device. And there was basically minimal survival and a fibrotic capsule that developed. So this was a little bit disappointing and probably reflects the hypoxic nature of the device, and probably the cells were suffocated or failed to develop appropriately for a variety of reasons. So this was disappointing. Based on the results of this study, they perforated the device. The study was done without immunosuppression in the unperforated device. With the perforated device, obviously they had to use immunosuppression. So they treated these patients with immunosuppression and implanted this perforated device with the same progenitor population. And this was reported recently in Cell Stem Cell of the results of 1-year follow-up. Some of the major findings, I would say, is that it was well tolerated, but unfortunately, the amount of C-peptide produced was fairly low. Insulin dosing and hemoglobin A1C did not really change in this population. The patients got a fair number of devices, as you can see there, with some morbidity from that. Nearly half of the patients experienced side effects, and many withdrew from the trial. So the last thing is that there was some alpha cell differentiation, which is not what we necessarily want in the cells after they're implanting and developing from progenitors. So I think this trial was recently published. To my mind, it was a little bit disappointing. So I think there's still room for improvement and room for development in this field. And although the entry into clinical trials is very exciting, I think there are some key next steps that we would like to see happen in the field to lead to better success. I think the key barriers are elimination of need for immunosuppression. That way we can offer a transplant for more patients and avoid the risks of immunosuppression, which of course are infection, malignancy, and other side effects. What we see as the solutions are either encapsulation or genome editing, and I'll show you some data of our work in the lab on the genome editing front. I think we need to achieve more robust dynamic function in vitro, that is prior to transplantation, so that when the cells go in, they are immediately functional we don't have to worry too much about them being rogue in terms of their differentiation and going to off-target cells. That will hopefully improve the potency as well. And I think that what I see as the solution here is getting to, again, more differentiated cells in vitro before transplant and showing dynamic function. One of the challenges is that if you're looking at an array of different conditions, different doses, different combinations of drug, you have a huge matrix of experiments. And to put that huge matrix of experiments through a complex perifusion assay, which is your readout, that's very difficult. So we've recently worked to identifying key transcriptional and protein markers of mature function that correlate with perifusion and correlate with maturity, so that we use these gene expression profiles, protein expression profiles as a guidepost towards getting that development and narrow down the matrix of experiments that are necessary. When I say matrix, I mean the grid of experiments, not the extracellular matrix. With looking towards achievable better function in a retrievable site, we want to avoid the liver. Subcutaneous site is one potential site we're working on, and I'll show you some data from the lab where we have a pancreatic extracellular matrix, which can improve the function and morphology of the islets, and also hopefully with endothelial cells lead to better survival in the poorly vascularized subcutaneous space. So the first thing I'd like to show you is some work in genome editing with the analogy of the invisibility cloak here from Harry Potter. That's the idea, that's the concept. And what we've worked on in the lab is a couple of modifications of the cells, imparting inhibitory signals by the overexpression of co-stimulatory genes like CTLA-4 Ig or checkpoint inhibitors like PD-L1, and then knocking out class 1 and class 2. Hopefully, as this cartoon shows, leading to better survival of the cells in an immune environment. So we're really at the beginning of these studies still, and I just show you that how we've made some cells and some early data in undifferentiated cells, but not in stem cell derived islets yet. This is Danwei Huang Fu, a very very talented collaborator at Memorial Sloan Kettering, who has an inducible Cas9 system we're able to modify the cells, and using this system by putting in guide RNAs for beta-2 microglobulin and the class 2 transactivator, and adding doxycycline, we can stably modify the cells to knock them out, these alleles. And so we've led to the knockouts, and based on the double knockout or single knockout cell lines, we can then use talons, or she has used talons, to overexpress CTLA-4 Ig and PD-L1 in a dual transgene, and this is doxycycline inducible. This is how that was done. It's the AAVS1 locus. This is on the H1 human embryonic stem cell background, and this was the targeting strategy. There's several other things you can do with this targeting strategy and methodology. This is what we've done so far. She has generated a number of different cell lines with different combinations of each of those 4 modifications. Some of the cell lines are shown here. What we've worked with mostly so far, the DKO-ICP cell lines. This is the double knockout inducible CTLA-4 Ig and PD-L1. What we've done so far is assess the pluripotency in vitro and in vivo. I'll just show you some studies with a couple of the cell lines. I'll show you one study which looks at taking the undifferentiated cells, putting them into humanized mice, and understanding what their immunogenicity might be, using growth of the cells, a teratoma growth of the undifferentiated cells, as a measure of rejection or non-rejection. So this is the experimental plan. We have with the NBSGW mice, another immunodeficient line, This is generated humanized system with neonatal thymus and umbilical cord blood CD34 positive cells with a collaborator, Matt Brown, in our institution. Once they show reconstitution by flow cytometry, we then can transplant 4, in this case, undifferentiated cell lines underneath the skin. Again, not stem cell derived islets, just undifferentiated cell lines. And then look at a growth, which would indicate immune protection, and reduced growth, which would indicate that rejection, the immune response is attacking and destroying the cells. Some of the data we have obtained so far shows that the non-doxycycline treated cells in black and doxycycline treated DKO-ICP cells in green. The green cells, the doxycycline treated cells, show a little bit more growth than the non-doxycycline treated cells, which might indicate some level of protection in these as these cells are in vivo. When we took the grafts out and stained them with CD3, you can see some of the results here. There was less CD3 positive or T-cell, pan-T-cell staining in the doxycycline treated grafts than in the non-doxycycline treated grafts. It's not zero though, as you can see. We want to do further staining here to see if there are any regulatory cells or to understand what those cells are doing in the graft, possibly. But really, we want to move to stem cell derived islet-like clusters from these cell lines, and that's our next experiment. So just show you that we're not the only ones working in this immune cloaking or immune evasive stem cell field. There are many people working in the field in terms of other lineages, and there's really some really fabulous publications out there. This is one that's recent in the islet world. This is by Ron Evans' group in San Diego, and they had human islet-like organoids and showed that in both a allograft model and in a xeno model that the cells that express the PD-L1 by lentiviral vectors showed better protection in a humanized mouse model or in a xenotransplant model than the cells that were not protected or did not express PD-L1. So this is promising that maybe even not just 4 transgenes, but maybe just one might be effective in protecting the cells. In the next slide, I just a couple slides, I show you very quickly about what we're looking towards in terms of a guidepost of mature expression profiles of the genes and markers of human pancreas development. We looked at a number of different genes. These are some of them listed here in expression both by protein and genes, but in human fetal pancreas stem cell derived islets differentiated by 2 different protocols in adult human pancreas and adult human islets. This is on the top of the 2 different protocols. One that develops urocortin-3, which is thought to be a marker of stem cell maturity, and then the different adult and fetal tissues using our negative and positive controls, for example, as where we can see how the genes are expressed under those conditions. And under these conditions, we see that urocortin-3 is not a perfect marker of maturity. It's been identified as a marker of maturity in rodent tissue, but it isn't the case in human tissue. And this is an example of good expression of urocortin-3 in human fetal pancreatic islets. I'll go through these more quickly. We've identified some genes that do increase in expression dramatically from the human fetal pancreas level to the adult human pancreas, adult human islets. Some of those are identified in red. Some of those have been known before, like MAF-A. Some of those less well known, like IEPP, 6263, chromogranin B, and others. Lastly, I just wanted to share with you some other things we're working in the lab to get better function in a retrievable subcutaneous site. And we're working on identifying ways of replacing the lost matrix from stem cell derived matrix or islets. And I'll point out that Paul Johnson's group has been a leader in this field in terms of identifying how the collagenase can get into the islet and damage the islet during the isolation process and result in an islet that has changed extracellular matrix, which can affect clearly the health of the cells and the survival of the cells after implantation. We've identified the same thing in terms of the collagen staining and laminin staining in an in situ islet on the top, isolated islet in the middle, and a stem cell-derived islet cluster on the bottom. You can see that the isolated islet and stem cell-derived islet extracellular matrix staining is very dysmorphic, very changed, both compared to the in situ islet. So we think there's many applications of a decellularized extracellular matrix hydrogel. And we're focusing on a spin decellularization as opposed to perfusion decellularization. And we've published that you can make a self-gelling hydrogel, which has nice properties that can be used for both transplant and patient developing a better microfluidic, microphysiologic system for in vitro drug discovery. We can generate little beads of these and droplets of this extracellular matrix, which is a human pancreatic extracellular matrix from discarded human pancreases that are used for research but not transplant. And we've studied how this can improve the beta cell function. This is some data with regard to glucose-stimulated insulin secretion. The morphology of the islets without the matrix is changed in culture over 7 days. With the matrix, it's more preserved. So we see better islet architecture and better preservation of islet endothelial cells as well. If we put in endothelial cells, we've had some in vivo data that shows that these islet vascularized endothelial and extracellular matrix grafts have better in vivo function in a minimal mass model, in an immunodeficient diabetic model. We think that this might be a methodology to improve the function of islets and stem cell-derived islets in the future. There's some graphs there, the IVEG graphs, the vascularized endothelial graphs with extracellular matrix versus islets alone subcutaneously. These are all transplanted subcutaneously. So let me end by just saying that we've seen some of the past and the evolution of beta cell replacement therapies and cadaver islet and pancreas transplantation. We can transplant a few patients that way. Many centers have. We're hoping to transplant more patients and offer this to more diabetic patients. What the future holds remains to be seen, but I think it's promising with regard to entry into clinical trials of stem cell-derived islets. Necessarily, I haven't talked about xenografts because we're not in that field, but there's plenty of great work going on there as well, particularly with the genetically modified pigs. Lastly, I'll just say thank you to our funding and some of the scientists that did the work in the lab, particularly Dan Tremmel and Sarah Sackett. I'll lastly thank Paul Johnson for being a gracious host and inviting me here. This is pictures and very fortunate for me to have a visit to Oxford and your prestigious institution. So thanks for your attention.